You used to be a good sleeper. You didn't even think about sleep, you just slept. And then somewhere in your 40s, that started to change. Now you're lying awake, mind running, waiting for sleep that won't come, or you finally drift off and wake up at 3 a.m. with your heart pounding and no idea why. Or you're waking up drenched in sweat, or you're somehow sleeping 8 hours and waking up exhausted anyway, wondering what is happening to you. If any of that sounds familiar, I want you to know there are specific, well understood biological reasons that sleep becomes harder in midlife and perimenopause. And once you understand them, the path forward becomes clearer. Today, I'm going to walk you through 5 reasons quality sleep can be so hard to come by for women in their 40s, and then we'll talk about what actually helps. Reason number 1, estrogen does a lot of jobs and perimenopause disrupts them. Most people know that menopause comes with hot flashes, and some people know that dropping estrogen levels can cause them. But what fewer people realize is the role that estrogen has in sleep. Estrogen is involved closely with temperature regulation, and estrogen helps stabilize the thermoregulatory system. This is the body's internal thermostat, which sits in a part of the brain called the hypothalamus. When estrogen fluctuates and declines, that thermostat becomes unstable. The result is hot flashes and night sweats, sudden surges of heat and sweating, sometimes multiple times a night. You wake up sweaty or even drenched and need to change your clothes or sheets, sometimes multiple times a night. This obviously fragments your sleep cycle and pulls you out of the restorative stages that your brain depends on. Secondly, estrogen governs the sleep-wake cycle itself. Estrogen influences the regulation of sleep architecture, the structure of how you move through light sleep, deep sleep, and rapid eye movement sleep. When estrogen is dysregulated, that architecture becomes less stable, independent of hot flashes. Women who don't have significant night sweats can still experience meaningfully disrupted sleep because of this second mechanism. Reason number 2, progesterone starts to disappear. Progesterone is the body's natural calming hormone. It is metabolized into a neurosteroid called allopregnanolone, which boosts the activity of GABA, the brain's calming neurotransmitter. This is a similar mechanism to certain anti-anxiety medications like benzodiazepines, such as alprazolam or clonazepam. When progesterone is present, it often helps quiet the nervous system, ease anxiety, and support restful sleep. In perimenopause, progesterone is often the first reproductive hormone to decline significantly, and as it drops, that built-in calm disappears. So if you've been pregnant, maybe you remember feeling exhausted in the first trimester. This is often because progesterone is rising dramatically during this stage. The opposite is happening in perimenopause, and this can be a major reason you have trouble sleeping. But there's a second layer to this: progesterone and cortisol. Cortisol is the body's primary stress hormone, and progesterone and cortisol have an inverse relationship. So when progesterone is low, cortisol tends to run high, and cortisol has a natural surge in the early morning hours, preparing your body to wake up and face the day. Without as much progesterone to buffer it, cortisol can spike, often at inopportune times, pulling you wide awake at 3 or 4 a.m., oftentimes with a racing heart, a busy mind, and less biological support to help you fall back to sleep. That 3 a.m. wake up that feels so characteristic of perimenopause, it's frequently a hormonal mechanism, and it does often respond nicely to hormonal treatment. Reason number 3, melatonin production declines with age. Separately from what's happening with estrogen and progesterone, there's another physiological change happening that affects sleep. Melatonin production declines. The pineal gland, which is a small structure in the brain responsible for producing melatonin, the hormone that governs the circadian rhythm and the timing of sleep, the pineal gland begins to calcify or harden as we age. So the result is less natural melatonin, which makes it harder to fall asleep at night and harder to stay asleep through the early morning hours. This happens independently of reproductive hormones, and it compounds everything else. By the time you're in perimenopause, you're dealing with disrupted temperature regulation, a depleted calming system, a cortisol surge, and a declining melatonin signal all at once. Reason number 4, sleep disorders you didn't have before. Perimenopause doesn't just change the hormonal environment in the brain, it also significantly raises the risk of sleep disorders that can directly fragment sleep, and these often go completely undiagnosed. Probably the most important and common of these is obstructive sleep apnea. Estrogen and progesterone help maintain muscle tone throughout the body, including the muscles of the airway. As these hormones decline, airway muscles become less sturdy during sleep, meaning the airway is more prone to partial collapse, causing repeated microarousals or tiny wake-ups so you can breathe, and that prevents deep sleep and the normally restorative sleep architecture. Add in the common abdominal weight gain that often accompanies elevated cortisol and is commonly characteristic of midlife weight distribution, and the risk increases further. But you don't need to have abdominal weight gain or obesity to have obstructive sleep apnea. Between 1/3 to 1/2 of postmenopausal women have at least mild obstructive sleep apnea. Because sleep apnea is still widely thought of as a condition that affects overweight men, it is one of the most underdiagnosed conditions in midlife women. It doesn't always look like snoring. It can look like sleeping enough hours and waking up exhausted anyway. Daytime fatigue you can't explain, mood that seems worse than your circumstances warrant. If that's you, a sleep study is worth asking for. Restless leg syndrome is another sleep disruptor that increases in perimenopause. This is an uncomfortable crawling or aching sensation in the legs that worsens at rest and makes it hard to settle into sleep. Low ferritin, the body's iron storage protein, is one of the most common and most correctable triggers of restless leg syndrome. So if you have symptoms of RLS, you may want to check your ferritin specifically, not just the red blood cell count, because you can be iron deficient without having anemia. Reason number 5, the psychological weight of midlife. This 5th reason is less biological, but no less real. Midlife is often referred to as the sandwich generation for a reason. Many women in perimenopause are simultaneously raising children, managing demanding careers, and beginning to care for aging parents. The mental load is enormous, and it often doesn't stop at bedtime. The mind that won't quiet, the 2 a.m. problem solving, the list that keeps running, these are common experiences for women in midlife. Now you have less support from hormones that provided a stable foundation for emotional resilience, and the psychological stress can start to feel really overwhelming. Chronic stress also elevates cortisol, the same cortisol that's already elevated because progesterone has dropped. A full treatment picture has to acknowledge this. Not to dismiss it as just stress, but to address it directly, whether through therapy, lifestyle adjustments, or prescription medicines when appropriate. So what actually helps? Understanding why sleep is disrupted points directly to what helps. Here's a practical picture. Hormone therapy. For reasons 1, 2, and to some extent 4, menopausal hormone therapy can be highly effective, addressing the estrogen-related sleep disruption, restoring some progesterone-mediated calm, and helping stabilize the cortisol pattern. This is an individualized decision that requires a full clinical conversation, but it belongs in the room. Cognitive behavioral therapy for insomnia. CBT-I is the first-line treatment for chronic insomnia, and it outperforms sleep medication in studies with effects that last long after treatment ends. It restructures the thought patterns and behaviors that perpetuate poor sleep, and it can even be helpful for the vasomotor symptoms, the hot flashes and night sweats, of perimenopause. Get a sleep study. If you're sleeping enough hours but waking exhausted, or if daytime fatigue is significant, obstructive sleep apnea and other sleep disorders are worth ruling out. Sleep apnea is highly treatable. CPAP is the gold standard, but milder cases may respond to a dental appliance. Treating sleep apnea can meaningfully change mood, energy, and concentration, and can also protect your heart and lung health. Next, check your labs. Ferritin for restless leg syndrome, magnesium for sleep quality and anxiety, vitamins D, B12, and thyroid function all deserve attention. This list is not exhaustive, but deficiencies in any of these can worsen sleep and mood, and correcting them can make a real difference. Morning light and daily movement. 10 to 20 minutes of natural light within an hour of waking up helps anchor the circadian rhythm and directly improves mood. Consistent moderate exercise like brisk walking improves sleep quality over time. So a morning walk outside gets both of these. And then there are also supplements. Melatonin can support sleep onset, particularly given the declining pineal gland function. Recommendations usually include trying a sustained release melatonin so that it is working through the night to help you sleep through that 3 a.m. wake up. And low doses are better too. Magnesium glycinate can also help support both sleep and anxiety. Oral lavender has a reasonable evidence base for anxiety and sleep, although caution not to use this in pregnancy because it has estrogenic effects. These are worth discussing as part of a broader plan. Keep an eye out for future videos that do a deeper dive into supplements that can help support sleep. Next, address the psychological load. Therapy specifically can be meaningful here, not because the sleep problem is psychological, but because the weight you're carrying is real and deserves direct attention and support. Cognitive behavioral therapy for insomnia addresses the insomnia piece. Broader psychotherapy can address the midlife stress piece. And when you are less stressed, sleep comes more easily. Insomnia in perimenopause is a solvable problem, but it usually requires looking at more than one piece at a time. I hope this gave you a clear picture of what's actually driving it and what a complete treatment approach might look like. Next week, I'm shifting gears a little bit and talking about something that doesn't get nearly enough attention: obsessive compulsive disorder in pregnancy and the postpartum period. It's one of the most under-recognized conditions in perinatal mental health, and it affects far more women than most people realize, and probably doesn't look quite how you expected. I hope you'll join me for that one. Subscribe so you don't miss it, and leave a comment if something in today's video resonated. I'll see you next week.